emergency, or perhaps an emergency on board an airplane. Here are my disclosures. And it really is all about first aid. What do we do at the scene? It's pretty scary, even for me as an emergency physician. I'm used to taking care of emergencies with my nurses around, with all the sophisticated equipment. When you're at the scene of an emergency and there is no equipment available, you have to think on your feet and you have to rely on your basic clinical skills. So I think it's inevitable that something's going to happen. It happens to all of us where a patient right in front of you, a person right in front of you, has a syncopal episode, a choking episode. There's all kinds of things that can go wrong in all different age groups, and we have to be prepared for this. I would say you could pretend you didn't see it. You could walk away. You could not respond at all, but I hope you wouldn't do that. I think we have seen in a variety of scenarios, including the explosion during the Boston Marathon a few years back, where it showed that bystanders play a major role in saving lives. So I hope all of us would have the courage to get involved, stay involved, and help out at the scene. And there are some states where you're required to help at the scene. Minnesota, Rhode Island, Vermont, a person at the scene is required to provide reasonable assistance. It doesn't really tell you exactly what you have to do. It may be just calling 911, but you can't walk away from the scene in those states. All 50 states have Good Samaritan laws to protect us. And so I would hope that rather than worrying about yourself, worrying about a lawsuit, you would stay and do the right thing and do the best that you can. So the Good Samaritan laws really do protect us in this situation. The goal is to get us to be involved in an emergency without being afraid of litigation. It doesn't prevent a lawsuit. I'm sure you know you can get sued for anything in the United States, but it makes it very unlikely because there's a very, very small chance that the lawyer is going to win their case if you make a mistake while responding as a Good Samaritan in an emergency. In fact, there's never been a documented successful suit against a physician who responded in an emergency. So this is what the law says, that you're not liable for civil damages in rendering emergency care unless your act constitutes gross negligence. So if you really do something crazy at the scene, there's a chance you could be sued, but it's extremely low. And also, you're not allowed to receive money at the scene. If they give you a reward, that changes your relationship. You're no longer a Good Samaritan. Now you're a paid consultant, and then you are at risk of being sued if there is a bad outcome. So don't take any money when you respond to an emergency. So act in good faith. Don't put your own life in danger. No one says you have to stop on the highway if it's a dangerous situation. If you can't pull over safely, you're not obligated to render assistance and probably shouldn't. If you do stop, you have to remember that you are obligated to remain with the patient until services are no longer needed. You can't say after you've stopped and respond and say, well, I have an 8 o'clock dinner reservation, I've got to get going. Once you stop at the scene, you really are obligated to help out until you can transfer care to another person. Don't force anyone to accept care, although do what a reasonable person would want you to do for them. Transfer to an equally qualified practitioner. So again, you can't leave the scene and say, well, the police are here, I'm going to get going. If there's a paramedic there, you could certainly transfer care to a paramedic. In fact, most of the paramedics want you to transfer care. They want to take over. This is what they do for a living. They respond to emergencies all the time, and they know that most of us are just amateurs at the scene. But the paramedics may be willing to let the doctor take over. If you say, I've been here for the last 10 minutes, I've been helping out, I want to stay with the patient who is now your patient. You have to be willing to go to the hospital. Probably a good idea to talk with their medical command. Those paramedics have a physician who's likely guiding them. Talk to that medical command and decide who's going to manage this patient. Is it going to be the physician, or are we going to transfer care to the paramedic? So again, do the right thing. Don't be worried about a malpractice lawsuit. Don't be worried if you're not 100% sure of what to do. Do the best that you can in this situation and stay calm. This is a line from The House of God. Many of you have probably read that sarcastic book, but I think this line is a good one. At a cardiac arrest, first procedure, take your own pulse. If your heart rate is going very rapidly, if your heart rate is more rapid than the patient in shock, you're probably going to have difficulty being effective at the scene. So stay calm, take your own pulse, and let's talk about a few cases here. Let's talk first about a choking child. So hopefully you're going to be comfortable managing a pediatric patient. We're going to get to some that are not pediatric cases, but I'm sure all of you are aware that choking is very common in pediatrics. There's about 130 deaths in 2017, Many involve food. In fact, if we exclude child abuse, this is one of the most common causes of accident or injury-related deaths in children less than 3 years. About 17,000 pediatric visits a year to the ED for children. And as I said, it's often food. Hot dogs are responsible for about 17% of the choking deaths. Balloons are responsible for about 29% of the choking deaths, and most of these are in toddlers. Ironically and sadly, we find balloons and hot dogs at pretty much every toddler birthday party. So this is a problem that we as pediatricians might want to work on. So here's a case. This actually happened to me. My next door neighbor frantically knocking, pounding on the door, saying his child is choking, his son is crying, gagging, drooling, has a weak cough, and there was a hot dog nearby. The father believes the child was eating this hot dog. What should we do? These are the things going through your mind. Should we make him vomit, stick our finger down his throat? Should we do back blows, Heimlich? Should we call for an ambulance? Probably always a good idea to call for an ambulance. So here's the rule. If the patient is coughing, if the patient's breathing and crying, we know they're moving air. That patient can cry effectively. They're probably breathing adequately. The idea here is to not be a hero. Don't do anything to remove the foreign body. Call 911, get the patient to the hospital, where this can be removed under controlled circumstances. But if we try to do something and we fail, it could result in complete airway obstruction. And we've taken a child who was managing okay and breathing adequately and make things worse. So you don't want to do that. So what happens while you're waiting for the ambulance? You notice his lips turn blue, he's limp. Well, now we have to do something. Now it is up to us to respond. We can't wait for the ambulance anymore. I'm willing to bet that most of you don't have these vagal forceps in your car or in your home. This is what we would use in the emergency department, but I know very few people carry this around with them. The key here is don't just stick your fingers in his mouth and think you're going to remove the foreign body. If you can see it, you can look in his mouth. If you can see the foreign body, you might want to reach in and grasp it. But if you can't see the foreign body, a blind finger sweep is likely to push the foreign body further back into the airway and cause more complete obstruction and more difficulty with removal. So if it is completely obstructed, if the patient's cyanotic, if he's not breathing effectively, if the cough is not adequate, if the patient clearly is unconscious, obviously you have to do something. So for a young infant, less than 1 year of age, the key is to do 5 back blows, and then flip the child over and do 5 chest thrusts right over the sternum where you would be doing CPR. And then you're going to do open his jaw and look inside, see if you can remove that foreign body without a blind sweep, but see if you can find the foreign body and remove it with your fingers. If the child's over a year, we would do the Heimlich maneuver. So here's what it would look like. 5 back blows between the scapula with the patient face down a bit, taking advantage of gravity as much as possible. Then we're going to turn him over, do 5 chest thrusts right over the sternum, and then we're going to open up his jaw and see if there's a foreign body that we can easily remove. If it's an older patient, we said we would do a Heimlich maneuver, which is a series of 5 abdominal thrusts with your fist just in the mid-abdomen and pulling up on the patient 5 quick times and repeating that if you're not successful in having the patient cough out the foreign body. If the patient is very large, you can't pick him up, or if he's unconscious and you can't lift him up, then we would do these abdominal thrusts in this manner with the patient laying on the ground, 5 upward thrusts, and then see if you can remove the foreign body. Then step back. You never know what's going to come out of this child's mouth, so be prepared for anything in pediatrics. All right, let's talk about a bad day at the swimming pool. You have a scene where there's a patient brought out of the swimming pool, a drowning 3-year-old. So there's many people screaming at the edge of the pool. You know something is up, and you find that there's a young child just pulled out. He's limp and motionless. What will you do? I hope you will run to the scene and not run away from this child. Drowning is very common, unfortunately, one of the leading causes of accidental death in young children, especially, and about 37,000 deaths in 2017. So it's usually young toddlers at greatest risk, and then we get to teenagers who are also at high risk. Now, most of the deaths are related to males. You know, boys are always doing dumb things, much more likely to be involved in injuries. And toddlers and adolescents, as I said, are the highest risk. And adolescents usually involved in diving incidents, not being aware of how shallow the water is, and maybe drinking at the scene. This is going to lead to major factors in adolescent drownings. And Young children, I'm sure you probably know, we need to have barriers around the pool. We need to have them supervised. And this, again, is something that we can do as pediatricians to prevent these drownings from occurring. So again, how do we respond? Don't put yourself in danger. If you're not a good swimmer, don't jump into the water after the patient. Certainly, if there's a rip current out in the ocean, don't even think of going in to try to save that patient. You're just going to end up with another emergency rather than saving the patient. So don't immediately jump in. Look around, see what's available. Maybe there's a rope available that you can throw to the patient. Make sure you tie that rope around the tree, because if you're holding that rope, that patient in the water is just going to pull you into the water. So if you find something, tie it around the rope so that you're not putting yourself in danger. And if you're not a good swimmer, don't jump into the water. Call for help. Call EMS if at all possible, and then look around for rescue equipment. Now, if you're at a swimming pool, there's a good chance that you're going to see rescue equipment nearby. Again, you have to know how to use this. Don't get pulled into the water with this equipment. Make sure you're secure before you throw it to the patient. And then stabilize the C-spine, especially if it's a teenager. As I said, many of them were diving into shallow water and they hit their head on the bottom of the surface. So it's especially important to stabilize the C-spine. Less important in young children. It has been shown that young children usually fall into the swimming pool rather than having a diving injury and a C-spine injury. And then when we get them to shore, we're going to be doing CPR. And I hope that you'll remember that if you're by yourself, it's 30 compressions and 2 respirations. If you have help, if you have someone to help you, it's 15 compressions to 2 respirations. So here's our patient just showing how to stabilize the C-spine. Obviously, these people are well prepared with a backboard. That would be ideal. But if you don't have the backboard and you're trying to get the child out of the water, just pulling their arms over the head of the patient, using their arms to stabilize the patient's neck is what's recommended. It's pretty hard to do CPR in the water. So unless you have a lot of help, unless you have that backboard, I wouldn't even attempt this. Get the patient out of the water as quickly as possible. And then we're going to do our compressions. We're going to check his airway. And then we're going to give rescue breaths if necessary. It's the CAV reminder for CPR. I would recommend, I'm sure you don't have a McGill forceps in your car, but it's not a bad idea to keep this in your car, a pocket mask, so that you would be more comfortable doing mouth-to-bag resuscitation, ventilation on the patient. Nobody wants to do mouth-to-mouth resuscitation anymore, but if you have this equipment with you, you might be more willing to intervene. So continue CPR. When the paramedics arrive, you do play still an important role. Tell them what happened. Tell them how long the patient was underwater. Tell them what was done. And let's get the patient to the hospital as soon as possible. All right, we'll go over another case here. Collapse at the gym. And this has happened, I'm sure, to some of you in the audience, where you're exercising at the gym and another athlete appears anxious, has beads of sweat on his forehead. He's agitated and uncomfortable, complains of chest pain, and then he slumps over. This really did happen to my chairman of our pediatrics department. He was my hero for a long time. He's a neonatologist, but he responded to the scene and helped a teenager, an adult, actually was a medical student, who collapsed at the gym right in front of him. So this is a situation. What are you going to do? The patient seems like he needs significant help. It's probably a cardiac event here. So this is where the CAV reminder becomes very important. Circulation is the most important thing. Then we're going to check the patient's airway, and then we're going to assess his breathing and breathe for the patient. This patient likely has a circulatory problem and a cardiac arrest. So providing CPR, again, 30 to 2 if you're by yourself, 30 compressions to 2 ventilations. If you're really uncomfortable with the ventilations, it has been shown that the chest compressions is definitely the most important thing. So if you just do the chest compressions, you're really going to help this patient significantly. Call for help, and if you're at the gym, the chances are very high that they have an AED. Almost every respectable gym will have an AED nearby. Airports have these at many sites throughout the airport. They're thought to be placed in high-risk areas where someone is likely to go down with a cardiac emergency like the gym. So paramedic response time may vary. If you're close by to a hospital, to an ambulance, a fire department, chances are they're going to come very quickly. But as you all know, depending on traffic, depending on where you're located, that response time could vary. So it really is going to be up to us to help defibrillate this patient. We need to be familiar with that AED, and we need to get to it quickly because it has been shown that for every minute that you delay in the defibrillation, the success of that patient, the success of the defibrillation will decline by close to 10%. So we want to get the defibrillator on the patient as soon as possible. Here's one, a sample defibrillator. This is one that we use at my hospital. There are many different brands, but they're all fairly similar. I would suggest if you have access to a defibrillator, an AED, that you look at it carefully, get familiar with it, so that if there was an emergency, you would feel comfortable using it. But even if you've never seen it before, the way most of them are made, they have these picture diagrams to show you exactly what to do. This is going to go over the patient's sternum, the blue strip, and then those patches, they have pictures to show you which one goes on the anterior chest, which one goes on the back, and when you're actually using the machine, it will guide you with steps all along the way and with voice prompts as well. So it's going to tell you what to do for the patient. In fact, you're going to hear many times, stay calm, because you need to stay calm in this situation and use that defibrillator effectively. So don't worry about shocking the patient inappropriately. The AED is only going to work if there's a shockable rhythm. That AED is going to recognize ventricular fibrillation if it exists. If it doesn't exist, it's not going to deliver the shock. But the machine will advise you that a shock is indicated. Please stand clear and get ready for the shock. So what do you do if it's a child? People are always worried, well, do they have pediatric pads? Am I going to deliver the wrong charge to a child? I wouldn't be too concerned about this. Many of the defibrillators, many of the AEDs have pediatric pads right in the kit there. So if you can find them for a young child less than 8, it is recommended to use those pediatric pads. If you can't find them, use the adult pads. Nothing will happen to the child. You can't make the child much worse than he already is. So use the adult pads if you can't find pediatric pads. But these pediatric pads will deliver a safe energy level for the child. The drawing on the package will show you exactly where to place these pads. You don't want to use an automatic external defibrillator if the patient is conscious. I don't think I need to tell you that. If he's conscious and breathing, he probably is not in defib and he doesn't need to be defibrillated. If he has a pulse, if he's in water, it's probably not a good idea to use the electricity from the automatic external defibrillator. So you do want to dry off his chest. If there's a sweaty patient who was exercising at the gym, drying off the chest is recommended. If it's a hairy chest, you might want to remove it. Some of the kits, most of the kits have a razor there to shave the chest. Don't spend a lot of time on that. It looks nice, but it's not terribly important unless there really is excessive hair. Apply the electrode pads to the patient's bare chest, and then follow the instructions of the machine to deliver that shock. All right, let's move on to the soccer match. We haven't been to many soccer games lately at crowded stadiums, but it's going to be happening again soon. So you're enjoying a soccer match, and a young child near you has a seizure. Everybody's screaming the child's going to die. A seizure can be very frightening, not just for the lay public, but for medical people. I do see this in my own emergency department. I see the medical students walking the other way. Oh, good time to check on some lab tests. I see nursing personnel panicking briefly when the child is having a seizure. It's very frightening, but I think we have to stay calm in this situation. So you find this child lying on the stadium steps, his arms and legs are shaking, his mouth and eyes are twitching, there's saliva coming from his mouth. What are your major concerns? Well, again, here the most important thing, is this child breathing? He probably is. Is he cyanotic? Is he breathing adequately? Is he oxygenating? Is his chest wall rising? And this can be difficult to tell sometimes. A patient is having a generalized tonic-clonic seizure, you may not see that chest rising as much as you think. But if he's not cyanotic, chances are he's adequately ventilating. Most people with a seizure will be able to breathe through the seizure. You're thinking in the back of your mind, what's the etiology of the seizure? Does he choke on something? Do I need to do something to look for a foreign body? Was it a traumatic event? Is there an ingestion? And the most important thing is, how can I prevent further injury? So you're trying to think of what's the etiology, but the reality is it doesn't matter all that much. You have a patient who's seizing in front of you, the etiology is not so important. We're still going to stabilize the patient regardless of the seizure. The only case that might matter is the patient febrile, and we might want to cool him down a bit. And if the patient has a foreign body, an anoxic brain injury, maybe there's a possibility that we can remove a foreign body. Otherwise, there's not all that much you can do about the cause of the seizure. Most seizures are self-limited. That's the good thing. Go to the patient, try to help out, and recognize that most of these patients, the seizure is going to stop. We only really worry if the seizure goes on for more than an hour. So if you're in some remote area where you can't get help, and the patient's seizing for more than an hour, well, then we're going to have a problem because there is a low mortality, but it's not zero, and it's usually a patient who has a prolonged seizure. Or it could be a patient who has a brain tumor. That's why they had the seizure, but they're going to be, the mortality is from their underlying condition, not from the seizure itself. So what should we do? Call the paramedics. There's a good chance this patient needs to go to the hospital. Pretty much anybody who has a generalized tonic-clonic seizure, even if they have a known seizure disorder, it's not a bad idea to have them evaluated at the hospital. So have someone call the paramedics, assess the patient's airway. Again, don't do a blind sweep. Don't put anything in his mouth. There's a chance that you could push a foreign body further back. Don't try to pry open his mouth unless there is a foreign body. It's not going to be easy to get his jaws open. With a tonic-clonic seizure, a generalized seizure, the chances are you're going to have trouble opening the patient's mouth. So assess his breathing. You probably won't have a stethoscope with you, but you can still assess his breathing. The reality is most patients with a seizure are breathing adequately. Most patients don't have trouble. You want to make sure that the chest is moving, but keep in mind that you may not see it all that well. You could try to do a chin lift or a jaw thrust maneuver if there wasn't trauma involved. You could always do a jaw thrust maneuver. If you think there may have been an injury, the chin lift is probably not the best thing. A jaw thrust would be better. Put a towel roll under the patient's shoulders. That may help to open the airway a little bit better, but don't hyperextend the patient's neck. Loosen tight clothing. This might make it easier for the patient to breathe. Don't put anything in his mouth. The old wives' tale, putting a tongue blade or putting something in his mouth to help him breathe, that is really not advised. The patient is not going to swallow his tongue. That really is an old wives' tale. The patient is not going to swallow his tongue. So assess his heart rate, his pulse. Usually that's not a problem. As I said, the mortality is very low with a seizure. Most of these patients are going to be breathing adequately, and very, very few of them have a problem with their heart rate and pulse when they have a seizure. So I think the key is to prevent further injury. Move him to a safe area so he doesn't roll down the steps during the seizure. Take any dangerous objects away so he doesn't hit his head against something and cause further injury. If the patient is vomiting during the seizure, well, then you have to move him a little bit. Try putting him on his side to prevent aspiration. But you don't want to keep him on the side. I think we all know that if you put the patient down on the side, then his lungs on that side are going to collapse, so it's going to be a little more difficult for him to breathe. So we're only doing this in the event of emesis. Try to get a history if the family's around. If they have a seizure disorder, if they have any medical problems, was there an injury? Has the patient been sick? Is there a possibility of a foreign body? Does he take any medication? You can get this history in about 30 seconds from the family. If he feels warm, you think this may be a febrile seizure, again, you could do nothing. Most kids will respond very well and recover very well from a febrile seizure, but you can consider cool towels. If you suspect he's hypoglycemic, you can consider putting some sugar onto his tongue, but obviously you don't want the patient to be consuming anything in this situation other than a small amount of sugar on the tongue. Don't do anything to obstruct his airway. You could think about diazepam if there's other people in the crowd. There may be some other people in the crowd that have diazepam, maybe rectal diazepam, that you could use to stop the seizure if it's going on for a long period of time, perhaps more than 10 minutes. Usually, if you're in a situation like this, like a soccer match, you're usually going to be able to get an ambulance to respond relatively quickly. And again, our job as first responders is to help the paramedics, give them a history, tell them what we found, tell them what we did. And I think our major role is to reassure the family that there's a good chance the child is going to do well at the hospital. Most children with seizures have a good outcome. All right, let's talk about a complicated one. You're on the highway, and right in front of you there's a motor vehicle crash. This really is the leading cause of death for children over the age of 5. 2.5 million injuries in 2018, 36,000 deaths related to motor vehicle crashes in 2019. Most of these occur during rush hour and also in the early morning hours when people are tired and maybe some drunk drivers on the road. So you're driving to the beach on a weekend, ready for a wonderful weekend with your friends at the beach, and just ahead of you there's a serious crash involving 2 cars, and there's multiple victims. You see an elderly woman ejected from the car, laying on the highway face down. There's a teenager screaming in the back seat that his leg is broken. There's a crying child strapped in his car seat in the back. And there's a young woman driver who's hunched over the steering wheel. So now it's just you, and there's 4 victims here. Who are you going to help first? Here you have to make a triage decision. Who do I help first? How are we going to react? There's going to be a crowd very likely. You may have to do some crowd management. And what's our plan, and are there hidden dangers? As I said, don't do anything if it's going to put yourself in danger. If you can't stop safely, don't stop. Call 911 and keep moving. But if it's at all possible to pull over, you do want to pull over and try to help these victims. Make sure that if there's any possibility that one of the cars is going to explode, don't go near that car. There's fire, gasoline. But if you are in a position where you can help out, take charge, speak to authorities, tell the rest of the crowd, I'm a doctor, a nurse, whatever, a clinician you are, and stand up and take charge of the situation. Reassure the victims, tell them not to move, have somebody call 911. That's certainly the most important thing in this situation, to get paramedics and tell them that there are multiple victims. So here's the triage criteria. And unfortunately, there are some situations you're only one person and you can't take care of all four of them, so you do have to decide. If the patient appears lifeless, if the patient's dead or has such a severe injury that there's minimal chance of surviving, don't spend a lot of time with that patient. What you want to do is go to the immediate care should be given to someone who has a life-threatening injury, but if we fix that patient, they have a good prognosis. So in this situation, we have this older woman who's lying on the street. She has no pulse, no respirations. This is a woman, unfortunately, you're going to have to leave her alone. Let somebody else manage her if you want, but don't spend a lot of your time as the only clinician there to help out here. That teenager who's crying at his broken leg, that one can wait a little bit. Delayed care. That young child who's screaming, crying in the car seat, if the patient's crying, we know their airway is open. Leave them alone. The first one I would go to in this situation would be the young woman who's over the steering wheel moaning. She needs immediate help because her airway may be partially obstructed. So open her airway with a jaw thrust. You may need to move her upright. So again, everyone's very worried going, move the patient. You don't want to injure their C-spine. So if at all possible, protect their C-spine. Hold your hands over their neck to protect them while you're moving them into a neutral position so that the patient can breathe a little bit better. Check the carotid pulse. In this case, her pulse is slow but present. And as soon as you reposition her, then she's going to start breathing. Her heart rate's going to come up. You might want to just hold her there over that steering wheel in a position where she's now breathing adequately and not take her out of the car. You don't want to risk an injury to her C-spine or to her back. Unless you think this car is about to explode, if there's a risk of fire, well, then you have to get the patient out as soon as possible and away from the car. So this is just some pictures showing how to stabilize the C-spine. You're probably not going to have a lot of equipment with you, so just holding the patient's neck in the midline position is the best thing that you can do. You should suspect a neck injury. If there's a head injury or face injury, there's a good chance there's a neck injury. If the patient's unconscious, certainly if they have any neurologic deficits, you should suspect a neck injury. If they're not breathing adequately, that could be a C-spine injury. And if there's unexplained hypertension, the same thing. So you might want to move the head and neck to a neutral position. You can't leave the patient laying in a funny position in the car if they're not breathing. You might have to move them to the neutral position, but you should stop. If while you're trying to do this, you notice neck spasm, you notice pain, or patients are waking up to indicate they're in pain, or there's resistance to movement, don't try to move that neck any further. So you might need to do something. If you have something in your car or nearby, you might improvise and make a C-spine collar. If you have a towel nearby, a blanket or shirt or foam pad, you must improvise and make a C-spine collar. You're obviously not going to have a hard Philadelphia collar with you in those situations. And I'm not sure how much these improvised collars are going to do, but at least they're going to remind you that this patient may have a neck injury. Don't move them at all, if at all possible. So I think it serves as a reminder, and it does provide some stability. So the young child in the car seat, if he's crying again, he probably is going to be okay. He's probably moving air, and we go in and find he has no apparent injury. He's alert. His color is good. You can consider stabilizing his C-spine, or just leave him alone. You could consider just leaving him in his car seat or get him out of the car. Maybe he'll be more comfortable if we can move the entire car seat. Don't take him out of the car seat, but take the whole car seat out of the vehicle and move it away from the car. And then allow other people to monitor him while you tend to the more seriously injured. The patient with a leg injury. He said he wasn't the first one we're going to attend to, but if he has some brisk bleeding that we find from an arm laceration, well, we do have to do something. We have to put pressure on his wound to try to stop the bleeding. If it's a severe injury, this patient could have a life-threatening bleeding problem. So a pressure bandage is recommended. Just apply direct pressure over that wound to stop the bleeding. If you're not successful with that pressure, then we're going to use a tourniquet. When his life or limb is threatened, we have to use a tourniquet. So we're going to tie a wide band. It could be a shirt, a towel, whatever you have available, a rope. But we're going to try to make a tourniquet. And the idea is to make sure this is a couple inches above the wound, proximal to the wound, in order to stop that bleeding. And then there used to be thought, well, you want to take it off every few minutes to make sure his extremity is okay. That teaching has gone away. We want to not loosen it until they get to definitive care. Now, if you're out in the wilderness and it's going to be hours before you get to help, you might have to release that tourniquet. But if you're in the city and there's help on the way, make it as tight as possible and don't release that tourniquet until they get to definitive care. Our goal is to minimize the loss of limb. So here's what it's going to look like. It should be at least 2 inches above, proximal to the wound. We're trying pressure first, but if pressure is not working, we're going to apply a tourniquet. There are courses now that you can take. It's a very short course, but you can take a course on stopping the bleed. At one time, tourniquets were thought to be a terrible thing, but I think, again, at that Boston Marathon explosion, it was shown how effective it can be. If you place a tourniquet on a bleeding person's extremity, you can really save a life. So we want to also apply a splint if the patient has a fracture. This is also important to decrease pain and prevent further injury. So our goal is to stabilize the joint above and below. And in some cases, we'll use an anatomical splint, just putting one leg next to the other or 2 fingers next to each other. As you know, those are anatomical splints. And then look around for whatever you have. Maybe you have something in your car. My wife always makes fun of me because I keep a golf club in the trunk of my car, but it may come in handy someday if I ever have to stabilize a patient at the scene. So a stick, a spoon, a magazine, whatever you can use to stabilize that extremity is going to be helpful in the short run. All right, and finally, we want to talk about emergencies on an airplane. What do you do if you're on an airplane and someone calls, is there a doctor on board? This is a difficult situation. First of all, it's not easy to get a history. You don't know these patients, and it's a loud, noisy environment. It's going to be very difficult to do a full examination. You don't have a lot of equipment with you. We'll talk about the equipment later. But you're going to be evaluating this person in a very cramped quarters in a narrow aisle or in their seat. On a crowded plane, there's a lot of noise, and most of us don't have a lot of confidence. Keep in mind, most of the time when they call for a doctor on board, it's going to be for an adult patient. Children are very rarely involved, 10 to 15% of the time. It's going to be a child. So how often are these flight emergencies? Well, it depends on which studies you read, but they're actually fairly common. 1 in every 600 flights. Most of them, fortunately, are not serious. The pilot is going to divert very, very rarely, in only about 5% of the cases, and death, fortunately, is extremely rare up in the air. There probably are more cases that we know about, and many of these don't get reported to a national database. Many of the patients have a pre-existing problem. Only 15%, as I said, are pediatric passengers. And here you can see the most common etiologies when they call for a doctor. It's usually syncope or dizziness, GI problems, respiratory problems. Cardiac problems are much less common, and neurologic problems like stroke even less common. And injuries, occasionally you'll have somebody who's burned or injured by falling luggage. You know how they say to be careful when you open the bin? It is true. Sometimes people do get injured by that falling luggage. So as I said, most of the time it's going to be an adult patient. Only 15% of these emergencies involve children. And this is what you see are the most common emergencies in the pediatric population. Death in a child is extremely rare on a plane. So one thing you should recognize is that you're not alone. Almost all major airlines can talk to a ground-based physician, an emergency physician from the Mayo Clinic, from the University of Pittsburgh, or some other private companies. You can talk with a board-certified, or at least you can talk indirectly with a board-certified physician. Unfortunately, only about 10% of the cases do people ask for advice on the ground, but don't be afraid. If you have a concern about a patient, say, I want to talk with the ground-based physician. So this is what it's probably not going to look like this. This is in a private jet plane where it's showing the doctor directly talking to a physician about their patient. It doesn't look like this, unfortunately. Most U.S. airlines have this crazy system where the flight attendant goes to the pilot. The pilot talks with the ground-based physician, relays the information to the flight attendant, who comes back and talks to you as the physician. I can't understand why we can't do a better job on this with all of our experience now with telemedicine, why we can't directly talk to the ground-based physician. But most airlines don't permit that. You should recognize that there's a lot of equipment on a plane. almost all of them, the larger airplanes, are required to have an AED and an emergency medicine kit. Unfortunately, most of these kits do not involve medications for children. I said most of the patients are not children, but when you have a child, you wish you had the pediatric equipment. The American Academy of Pediatrics was very vocal in supporting the Airplane Kids and Trauma Safety Act in 2018 to get this passed, and it's still working to get pediatric equipment on these airplanes. They all have oxygen, and they're all going to have a basic first aid kit in addition to the emergency medicine kit. And also, don't be afraid to ask for a passenger. This is not the time to be shy. Does anybody have an inhaler? Does anybody have an EpiPen? You could ask. There's plenty of passengers who may be willing to help out in that situation. This is what a sample emergency medicine kit would look like. Not the simple first aid kit, but the emergency medicine kit. And don't be worried about knowing what's on it. There's going to be a list. The first thing you'll see is a list of equipment that you should be able to find on this emergency medicine kit. And here's what the equipment might look like. Again, you don't need to memorize this. You'll see that equipment list right in the kit itself. Still, with all this equipment, don't think that you're going to have everything that you need. You may need second or third doses. There may be a few doses, but there's not going to be a lot of doses. There may be tourniquets. There may be IV tubing. But if you miss several times, you're going to be out of equipment. There's not even enough oxygen to last for the entire flight in many situations. So what should you do? Well, again, in some countries, you are obligated to help. In France, Germany, Australia, you are legally obligated to help. In the UK and US and Canada, you don't have a legal obligation, but I hope you will do the right thing. There are some passengers, some doctors who will sit on the plane and pretend they're sleeping or they're reading a magazine. Oh, I didn't hear them call for a doctor. I didn't hear them call that. But I would again hope that you would stand up and do the right thing in this situation. Don't be worried about malpractice lawsuits. Just like the Good Samaritan Act, there is the Air Carrier Act that will protect you if you act in good faith. Don't accept money. As I said, that's going to change your relationship. Now you're a paid consultant and you are at risk for malpractice. If the flight crew offers you a free drink or a move up to first class, that's not considered compensation. You can accept that, but don't take money from the passenger after you've rendered assistance. Identify yourself to the flight crew. It's rare that they're going to ask to show proof, but if you have a business card, you might want to show that you really are a doctor or a nurse or whatever. If you're going to ask for the emergency medicine kit, well, then they are going to ask to see who you are. And they don't want you giving out medications unless they know that you're a doctor. Always act within your capabilities. Do no harm. Always try to get consent from the patient unless they're incapacitated. Try to take a history from the passenger or maybe a friend that they're flying with to give you their medical history. You may need an interpreter in some situations. And don't be afraid. Even though this is an adult patient, you know how to examine a patient. Go over to the patient, listen to their heart and their lungs. Request the emergency medicine kit if this looks like a serious emergency. You don't have to open it. Once you open it, well, then they have to do a replacement. But get the emergency medicine kit, not just the first aid kit. Tell them we want the equipment nearby just in case, and only open it if you need to. Tell the flight crew what you're worried about. Request communication with a ground-based team if necessary. And if you are going to give medications, make sure you document what you gave, what you did for the patient. I think we fail in this situation. We respond to a lot of emergencies on a plane, but most times there's no report. If you give medications, it's strongly encouraged that there's a written report of what was done to the patient. So in some situations, we have to consider diversion. Hopefully by now you've talked to a ground-based crew who's going to advise you about whether the pilot should divert. Keep in mind that it's the pilot's decision. They're the ones that have to decide what's safe, not just for that patient, that passenger, but for all the passengers. And the pilot has to decide whether it makes sense to divert the airline and land very quickly. You might recommend it if there's a cardiac arrest, a stroke, severe chest pain, severe abdominal pain, unresponsive patient. These are situations where diversion should be recommended, but it is going to be up to the pilot. All right, a couple of quick cases. You're flying over the Rocky Mountains. You're asked to help. There's a 3-year-old girl in row 12. She took some peanuts from the boy in row 11. A very romantic interlude going on here on the flight. Unfortunately, this 3-year-old girl has a known peanut allergy, and now she has stridor, hives, and swollen lips. So what will we do in this situation? Well, we would like to give an EpiPen. There will not be an EpiPen. Unlikely to be an EpiPen in that emergency medicine kit. There'll be epinephrine, and you can draw that up on your own, less than 0.5 ml. Remember, a small dose of Epi 1 to 1,000. But you could also ask passengers, does anybody have an EpiPen? There's a good chance that somebody on that flight has an EpiPen, and you would want to use that through the patient's clothing immediately if possible. As for the emergency kit, if you don't have an EpiPen, then you're going to draw 1 to 1,000 epinephrine and give this intramuscularly. The maximum dose is 0.5, somewhere between 0.3 and 0.5 ml. Don't worry so much about the per kilogram dose. 0.3 to 0.5 ml for a patient who's having a severe allergic reaction. And then, if possible, you might consider starting an IV and giving saline and steroids. But remember, the most important thing in treating an emergency allergic reaction, anaphylaxis, is that epinephrine. The saline and steroids are bonus. And so if you can get an IV started and give those, that would be great. But you could also give diphenhydramine. If the patient's awake and alert, we can give that orally or IV. You may need to repeat this epinephrine and talk to a ground-based. All right, final case. A 78-year-old woman passes out in row 20, seat B, crowded airline. She's in the middle seat. This is not going to be fun for the pediatricians. She's complained of chest pain to her friend earlier. She has a history of hypertension and heart disease. She's sweaty, pale. She's responding to commands. She has a long list of medications. This reminds you why you went into pediatrics in the first place. But we have to do something in this situation, right? We have to respond. This does not sound like a vasovagal episode. This sounds like this patient needs our help. Don't panic. Stay calm. Just as we said earlier, take your own pulse and stay calm. Ask for help. There may be somebody else on board who can help you, and I've had this situation several times. There may be a nurse on board who's quite comfortable with older patients. I once responded to an emergency with a family medicine doctor. He was not comfortable with an emergency, but I was not comfortable with the adult medication. So the two of us worked together to help an older patient. So there may often be someone who can assist you. Identify yourself and your skill set. Do no harm to the patient, but this patient seems like it needs our help. Ask for the emergency medicine kit, not just the first aid kit. We want the real emergency medicine kit. We want to give oxygen to this patient. I think all of us will be comfortable giving that. In very few situations where oxygen is going to be harmful. I can't really think of any. Give oxygen to the patient. Clear the area so we have some room to work. You might need to move this patient or get everybody else out of that aisle seat. Get the patient onto the floor if necessary, where you have more room to help the patient. And then examine the patient. I think all of us, even as pediatricians, can determine, is this patient hypotensive? We can take a blood pressure. There will be a sigmometer on the plane. Is she perfusing adequately? What's her cardiac rhythm like? Is it irregular? Do we need to give glucose? Remember, in an adult patient, it's 50 at D50. We don't have to worry about a per kilogram dose. 50 mLs of D50 would be the dose for an adult patient. And if you're worried about a cardiac problem, aspirin and nitroglycerin are usually pretty safe. Unless the patient is really hypotensive, then you might skip the nitroglycerin. It's recommended to give aspirin and nitro quickly to a patient with chest pain, an adult patient. And use an AED. We're not going to deliver a shock to this patient, but the AED may also help you to assess the rhythm on this patient. And so you might want to set that up just so you can tell what rhythm the person has. Consider some other medications. I would definitely talk to the ground-based crew if at all possible in this situation and talk with them about whether it's wise to divert the plane and to land quickly to this patient. So the bottom line is do the best you can, stay calm in all situations, and I hope that as a result of my conference you will stay calm and you will consider using an AED, become familiar with an AED in a cardiac emergency or the sudden collapse of an adult or a child. Thank you very much.